All right, welcome to this rapid-fire clinical explainer. Today, we are diving straight into urological emergencies. And let me tell you, the stakes here are incredibly high. We're talking about scenarios where a single, split-second wrong decision can lead to absolutely catastrophic patient outcomes. So let's jump right into the questions.
So the absolutely crucial point we have to establish right off the bat is what we call the reconstructive golden rule. The foundational concept in reconstructive urology is preserving tissue. It strictly dictates that you never ever circumcise an infant who presents with any structural penile defects, things like hypospadias, pepispadias, or ambiguous genitalia. That seemingly extra-preputial tissue, it isn't just spare parts. It is premium essential reconstructive material that a pediatric urologist is absolutely going to rely on later to harvest vascularized flaps and essentially build a new urethra.
Okay, moving into Section 1, Pediatric Urological Congenital Anomalies, where it's all about preserving tissue and relieving obstruction.
Let's dive right into question 1. What is the absolute contraindication to routine newborn circumcision? The correct answer here is epispadias. You see, conditions like epispadias or hypospadias feature this structurally hooded foreskin. If a practitioner prematurely circumcises this infant, they are literally throwing in the trash the exact vascularized local flaps needed for a future urethroplasty. It's a huge mistake. Now, in contrast, conditions like phimosis, paraphimosis, and balanitis xerotica obliterans, those are true pathologic indications where a circumcision is actually therapeutic.
Moving on to question 2, which looks at the classic triad of ventral hypospadias. The most common physical anomaly associated with it, it's cordy. Alongside a proximal urethral meatus and that hooded foreskin we just talked about, these patients present with an abnormal ventral curvature of the penis. Why does this happen? Well, it's because of the fibrotic tethering of the dysplastic urethral plate. And listen, if this structural bending isn't surgically corrected through a process called orthoplasty, it directly sets the patient up for severe mechanical sexual dysfunction later in life.
Which leads us to question 3. What is the gold standard fix for distal hypospadias? For distal to midshaft hypospadias, where that cordy is minimal, your gold standard is the tubularized incised plate urethroplasty, or the TIP procedure for short. The steps are actually elegantly simple if the anatomy cooperates. Step 1, you isolate the urethral plate. Step 2, and this is where the real magic happens, you make a midline longitudinal relaxing incision right down the center. This specific cut allows the edges of a soft, pliable plate to fold perfectly over a template catheter. It forms this nice, wide neo-urethra while keeping stricture and fistula rates super low. But remember, this single-stage reconstruction only works if there's minimal ventral cordy.
Jumping to question 6, what's the most common cause of mechanical bladder outlet obstruction, or BOO, in newborn boys? The correct answer is posterior urethral valves, or PUV. Imagine these abnormal, hypertrophied mucosal folds inside the prostatic urethra acting literally like a physical dam against the flow of urine. You've really got to watch out for the classic clinical triad here: a palpable distended bladder, a weak dribbling stream, and bilateral hydronephrosis that you'll see on ultrasound. And the definitive fix? It can't wait. It demands immediate transurethral endoscopic valve ablation to prevent secondary congenital renal failure.
Question 7 focuses on the pre-op PUV urine sample, and it brings us to a really critical safety check point known as the urinary cleansing mandate. Say you draw a pre-op urine sample from an existing suprapubic catheter. Well, you might get a false positive. That's because the bladder is holding massive volumes of stagnant residual urine that colonizes the indwelling line, but it doesn't represent a true systemic infection. To get a valid sample, you absolutely must place a temporary transurethral Foley catheter, ditch that stagnant fluid, and test the fresh sample. Why does this matter so much? Because doing high-pressure endoscopic instrumentation in an actively infected bladder outlet can easily trigger fatal gram-negative bacteremia, not something you want to risk.
All right, shifting gears to Section 2, Pharmacological Erection Complications. We're going to look at acute emergencies versus chronic risks.
So let's map out the risks of intracavernosal injection, or ICI therapy, on a timeline. This therapy uses vasoactive agents to manage erectile failure, but the complication timeline is pretty stark. On the left side of our timeline, we have the immediate acute emergency happening within 24 hours, low-flow ischemic priapism. Then on the right side, at the 6-month mark of continuous therapy, we see the chronic, long-term injury, cavernous penile fibrosis. This fibrosis acts a lot like Peyronie's disease. It's caused by chronic microtrauma and chemical irritation from the drugs, which eventually leads to irreversible collagen plaques and permanent curvature.
Going back to that acute 24-hour window, ischemic priapism is a literal life-threatening scenario for the erectile tissue. Excessive vasoactive dosing blocks the venous outflow entirely. It traps deoxygenated blood and skyrockets compartment pressures. If you leave this untreated for 24 hours, the tissue is permanently destroyed. So the definitive treatment requires urgent cavernous blood aspiration, checking blood gases to verify the ischemia, and, this is the big one, local irrigation with a diluted alpha agonist like phenylephrine. Phenylephrine is necessary here because it induces smooth muscle contraction, breaking that cycle and finally restoring the venous drainage.
And that brings us to our final block, Section 3, Traumatic Urethral Disruption Injuries. This is high-stakes trauma, and it all revolves around the catheter rule.
Questions 8 and 9 are all about urethral injury mapping, and brilliantly, predicting the injury is entirely about understanding the mechanism. If a patient suffers a straddle injury, say falling astride a beam, their perineum is forced upward. This mechanically crushes the anterior segment, specifically the bulbar urethra, right against the pubic symphysis. On the flip side, if a patient is in a high-speed collision and sustains a pelvic ring fracture, the trauma violently shifts the pelvis, tearing the posterior segment, which is the membranous urethra. So the mechanism flawlessly predicts exactly which anatomical zone is destroyed.
Moving to questions 9 and 11, you've got an unstable pelvis and blood at the urethral meatus. What is the correct next step? Your immediate next step is the gold standard imaging study, a retrograde urethrogram, or RUG. Standard CT scans just map bone. They are useless for evaluating the thin mucosal lumen of the urethra. For the RUG technique, you gently use 1 to 2 milliliters of water to seal a small foley in the distal fossa navicularis, and then retrogradely inject 30 milliliters of water-soluble iodated contrast. And here is a massive warning: never, ever use barium. Barium extravasation into torn pelvic tissues causes severe, chronic chemical granulomas.
Which brings us to the absolute climax of this trauma section, the single most critical exam pearl, the catheter rule. Listen closely. If your retrograde urethrogram shows contrast leaking out into the surrounding tissues with zero flow making it up into the bladder, you are looking at a complete urethral tear. Under no circumstances should you ever attempt to pass a transurethral Foley catheter. None. If you try to blindly push a line through, the tip of that catheter will easily convert a salvageable partial tear into a catastrophic complete transection, massively worsening an already terrible injury.
Let's apply that rule to question 10. You have a straddle injury, the patient is unable to void, and there's a palpable distended bladder. What's your correct action? Because the anterior bulbar urethra is likely crushed and completely torn, transurethral access is totally out of the question. The correct life-saving action is immediate percutaneous suprapubic cystostomy. Placing an SP tube safely bypasses the entire trauma zone. It diverts the high-pressure urine directly out of the bladder, which allows all that local perineal swelling and hematomas to fully resolve on their own.
Question 12 covers membranous rupture management, and we rely on what's called the delayed anastomotic standard. If you attempt an immediate primary open repair right there in the ER, you run a massive risk of severe hemorrhage from the pelvic venous plexus, not to mention sky-high rates of permanent impotence and incontinence. Instead, the true standard of care is to place that suprapubic tube and just wait. By deferring the definitive anastomotic urethroplasty for 3 to 6 months, you give the pelvic hematoma time to organize. Plus, the displaced prostate naturally descends back down into close anatomical proximity with the bulbomembranous junction. It makes the delayed surgery significantly safer for everyone involved.
Wrapping up the clinical presentations with question 13, which focuses on the posterior disruption triad. It's an unmistakable triad: a pelvic fracture, blood at the urethral meatus, and crucially, a high-riding or impalpable prostate on a digital rectal exam. That floating prostate means the puboprostatic ligaments have been completely sheared off. Transurethral catheterization here is both impossible and incredibly dangerous. Your correct, and really only, next step to establish bladder drainage and stabilize this patient is, you guessed it, a suprapubic cystostomy.
So, as we close out this explainer, I want you to take a second and reflect on everything we just covered today. Across pediatric anomalies, pharmacologic complications, and severe pelvic trauma, what is the unifying rule of urological intervention when anatomy is distorted? Well, in urology, when the anatomy is distorted, having patience, preserving vital tissue, and absolutely avoiding blind forceful interventions are the keys. That's what will consistently save your patient. Keep that in mind next time you're on rounds. Thanks for joining me today.